Good day, everyone. I'm Bill Falone. I'm the president of the Northeast region of the WOCN. Thank you for joining us on this presentation, which I think you're really going to enjoy. I have two very, very experienced professionals with me today who are going to be speaking to you about substance use associated with wounds, a harm reduction approach. I have on the top of the screen, Rachel Neuschatz, MSN RN. She is a harm reduction wound care field nurse with the Division of Substance Use Prevention and Harm Reduction in Philadelphia with the Department of Health. Rachel is the harm reduction wound care field nurse in the Philadelphia department. Rachel's experience, it's interesting, and I just had a preceptor experience with Rachel, so I was thrilled to death to be able to include her as a speaker. Rachel's experience includes community clinic, hospital, home, and street-based settings that helped to form this new role that was created to respond to the current increases in substance use-associated wounds. In addition to providing direct care in the community, Rachel is involved in efforts to strengthen coordination and education amongst those providing care for people with those wounds in varied settings. Rachel is currently completing her clinical rotation in preparation to become a certified wound care nurse. Second, but not second, on this whole thing is Lydia Williams, another special person who was, I guess, not harmed by my precepting, so it's all good.
Never.
Lydia is a WOCN and a family nurse practitioner, and she works for the Project Home Pathways to the housing clinic. Lydia Williams is a family nurse practitioner with over 10 years of experience. She has been certified in wound, ostomy, and continence care for 15 years. She currently works in Philadelphia at Project Home Pathways to Housing Clinic, a federally qualified health center specializing in providing care to those who are currently or previously unhoused with complex medical conditions, substance abuse, substance use, and mental illness. Lydia is passionate about health equity and believes that it is the key to improving health outcomes and quality of life. Lydia is an advisor and consultant for the Health Federation of Philadelphia, working to improve evidence-based wound treatment for people who inject drugs. She received her Bachelor's of Science in Nursing from Widener University in 2005, her wound, ostomy, and continence certification from LaSalle University in 2008, and Master's of Science in Nursing from Villanova University in 2012. I think you're really going to enjoy this talk, and I thank both of you for including yourselves in this in our conference. Thank you.
It's great to be here. Thanks for the invitation.
Yes, great to be here. Really excited.
All right.
All right. So we're going to start out going over our objectives. So after this session, we're hoping that you all will be able to define harm reduction and apply its principles to wound care plans and patient interactions. We're also hoping that you will be able to discuss basic xylazine information relevant to patient and population care, and also identify key clinical assessments and management strategies common to xylazine-related wounds.
So we're going to do a little bit of background of how Lydia and I provide harm reduction wound care, which both of us do daily in our jobs. Harm reduction is just one of many frames that are becoming more and more common in clinical care, such as trauma-informed care, person-centered care, informed consent, strengths-based, as ways to center humanity in clinical practice. And these frameworks are a means to help us as providers, as clinicians, fulfill one of our basic responsibilities, which is to respect everything that we don't know about the patient, about the person sitting in front of us. Harm reduction as a movement has its root in the 80s in the AIDS crisis and often is associated with substance use and related interventions such as syringe exchange. And that is absolutely correct and effective as a way to apply it, but it can also be applied to anything, not just drugs, to any behavior. since almost everything that we do can potentially have an undesired or a harmful side effect that we might want to minimize. So in this way, harm reduction is judgment neutral. It does not have abstinence as the goal, and it is based on the assumption that the behavior, whatever it is, drug use or otherwise, will continue, and that regardless, this person is worthy of dignity, autonomy, and care. So it allows us to refocus the clinical interaction from being an isolated event to being a longer relationship of therapeutic interaction between the patient and the clinician, with the hopes that not just that clinical encounter will happen, but in fact, a future one will also be able to happen as well. So that can look like focusing more on the relationship rather than any particular clinical results, can look like what we like to call the Power Ranger model of clinical care. So I know a bit about clinical science. Patient in front of me knows a bit about their body and their life, and with our powers combined, we can achieve health and care. Harm reduction can encourage us to ask questions rather than relying on assumptions about the person based on their identity in a particular population. And all of this means that harm reduction care might look a little bit different than traditional care. So for wound care, for example, we may not have closure of the wound as the goal, regardless of if the person may be young or free of other chronic illness. We may instead want to focus on maintenance and avoiding complications, knowing that the path forward to healing may be nonlinear. So one of the ways that we incorporate harm reduction into our practice is through street medicine or street-based care, with both Lydia and I do every week. Street medicine is also a movement started in the 90s to provide care to people who are unhoused where they're at on the street, rather than where clinicians ourselves are usually at in an office or a hospital. It's growing rapidly, which is great because there is a dire need. In the US, we recently got an ICD code specific to street-based care, so it is gaining traction. We find this to be particularly important to use this type of care with people who use substances because of the documented very high rates of co-occurring substance use disorder with housing instability, as well, of course, as PTSD, mental health, etc., all of which compound the barriers that already exist to accessing care, both infrastructural and facility, as well as provider stigma, which itself is a barrier for many people to access care, particularly if they're from a marginalized community. As a system, we're already moving towards this direction, right? So moving away from merely hospital and clinic-based care to more open community, home-based services, and again, now the street. And this allows us, the further outside of the hospital or the exam room we get, the more we see the need for harm reduction type care, the more we see all of the daily circumstances of our patients' lives that are out of their control and thus very much out of our control. That doesn't mean that we don't need to discuss those things. We can still talk about even very obvious issues that may be out of anyone's control, with the goal, again, through a harm reduction lens of maximizing safety and well-being of our patients. So where I practice, my job right now is with the Philadelphia Department of Public Health in the Division of Substance Use Prevention and Harm Reduction. The position Harm Reduction Wound Care Field Nurse was created about 1.5 years ago. And it's a 50-50 split between direct care that we do through community outreach with various partners, where in the last 6 months, we've seen over 600 people, some people for the first time, people who've never accessed wound care before, some people who we see quite regularly at various sites. We also provide supplies separate from care, as well as educational materials, and we're involved in a number of collaboratives that are working on using case review, for example, to provide additional guidance and recommendations around harm reduction wound care for substance use associated wounds. One of the community partners we have is Prevention Point, which is Philadelphia's syringe exchange, again, since the 90s, and offers a lot of other wraparound homeless services and clinical services. The wound care clinic there has existed since 2015, although in the last several years, they have increased annual visits 5-fold. We are a nurse-led clinic, and we do our best to do very, very low barrier or no barrier care as much as possible.
I practice currently as a family nurse practitioner at Project Home Health Services. Project Home is a Philadelphia-based nonprofit organization that's been combating homelessness and poverty for 30 years. They provide street outreach, a range of supportive housing, healthcare services, and community service. So I work for the healthcare services division. They have 3 clinics, one in North Philadelphia, the other that's in Suburban Station, which is in Center City, Philadelphia, and then Pathways to Housing, which is inside of another organization, Pathways, that provides social services and housing. And then I also, there also is the street medicine team, which I am a part of as well. And so that's part of a new program in the past year, actually. So on the street, we're doing street-based primary care, urgent care services, and wound care with a focus on people who are reticent to seek healthcare services in traditional settings. So the majority of the people that I'm seeing for wound care, and a lot of the folks that Rachel are seeing as well on the street, these are folks that wouldn't necessarily go in somewhere to get care. And so we're meeting them where they are to provide the care. And then I work at Pathways to Housing, which I said is office-based primary care. And we have a large population of patients that we are treating with Suboxone for opioid use disorder. We mostly see the participants of Pathways to Housing, but we do have a few patients that we see that are on the side. So we have lots of services throughout Project Home to kind of hit all of the patient populations.
So in order to talk about substance use associated wounds, we need to talk about xylazine. Xylazine is a drug that is becoming more and more well-known and is appearing more and more in the news, both for the severe necrotic wounds that we see with it and its impact on overdose and withdrawal. However, people using drugs have been aware of xylazine and its implications for causing wounds for over a decade. So as early as 2009, people who used drugs in Philadelphia, xylazine was noted probably the earliest, were noting wounds and connecting them to xylazine. Many people call xylazine tranq since it is a veterinary tranquilizer. So in this direct quote, this person who uses drugs says, basically, it's like the body is rotting. People here are losing limbs like with gangrene. Whatever they're doing with the tranq, everyone is getting these scabby sores all over their body. And shortly after, somewhat after, people who use drugs were noting this, the city of Philadelphia also became aware and began documenting presence of xylazine in decedent data for people who had died from overdose, opioid overdose specifically. So as you can see here, it starts in the Kensington neighborhood and spreads outward in Philadelphia. Both Lydia and I work a lot in the Kensington neighborhood. It was the first initial ever documented xylazine was in 2006, became more common in the 2010s with the shift from heroin to fentanyl. And since perhaps about 2019, it's been basically ubiquitous in the street opioid supply in Kensington. Currently, if someone is using street drugs and obtains an opioid-based substance, which we call dope, to inject or snort or smoke, that substance is rarely any more heroin. Since, again, throughout the 2010s, early in the 2010s, fentanyl became the primary drug in dope in street opioids rather than heroin, and has a few implications that go along with that. Fentanyl is a lot stronger than heroin, but also has a much shorter duration of action. So people have been needing to inject a lot more, and we have seen a lot of harm related to wounds and beyond from that. But it's not just in Philly. We're seeing it now spread throughout the US. Even some of the states on here, despite this map being from this year, are say that they haven't seen xylazine, but we now have been getting confirmation that even some of the places on this map that are missing have in fact seen xylazine, which means that there's a very rapidly growing population of people who are experiencing these wounds and the various complications, which can be sepsis, which can be limb loss, and which is definitely difficulty into getting into substance use treatment. Many substance use rehabs and detoxes do not accept people with wounds. So it creates a very difficult situation for people experiencing both wounds and substance use to figure out a way out. So this issue is going to get worse before it gets better. There is a large specialized population of people who both use substances and have severe chronic wounds. And so we need people who know how to treat them. Xylazine was added to the drug supply not by users, but by dealers. Users became unable to avoid it, and many are now chemically dependent on it. The idea is that it was added to fentanyl, again, in that shift from heroin to fentanyl, to prolong some effect from fentanyl. It importantly does not have all the same effects. Xylazine is synergistic with opioids and has some of the same impact on the body, but it is not an opioid, and that ends up being quite important when we look at things like naloxone does not work for xylazine. The recommendation is still to give naloxone if you're concerned about overdose, since we do see them together, but it does not directly work on it. Xylazine doesn't relieve the symptoms of opioid withdrawal directly, and buprenorphine, which we use in Suboxone and many other drugs for drug treatment, substance use disorder treatment, do not directly affect xylazine either. What we can see in this graph is that xylazine can be thought of in some ways as similar to a benzodiazepine, so they are both CNS depressants. But what this graph indicates is something that I think shows us something quite important about substance use. So we can see as the orange line of xylazine increases, a mirror image line, blue line of benzos decrease. While it is true that people don't choose or control their drug use entirely, benzos are often consumed as pressed pills separate from a bag of dope. And so people have a lot more control over consuming that. And what this indicates is that people are not necessarily seeking to be ever more inebriated, but in fact, many people are self-medicating for very real traumas that may have contributed to their substance use and or traumas that they may have then experienced since they have become homeless, for example. Xylazine is, as we said, not an opioid, not a benzo. It is a sedative that is used in veterinary medicine only. Generally, it belongs to the alpha-2 adrenergic agonist class, so similar to clonidine or tizanidine, etc. But in the street drug supply, we see it in much, much, much higher doses than we ever would see it or use it therapeutically, clinically. It hits quite quickly, often within 20 minutes. It has a very prolonged duration of action, so 4 to 6 hours, and it's very quickly metabolized. So we may not see it come up, for example, in a urine screen, but that may not indicate that someone is not using xylazine and does not need treatment for xylazine withdrawal. Both of those may still be necessary and true. So because it is not studied in humans, we not only don't know what it does to the human body, but we also don't know what it does beyond the use for discrete surgeries, so at high doses daily for years. What we have seen in the time that xylazine has been on the streets is a concurrent increase in wounds, severe increase in wounds, and many of the complications that go along with them. So this graph is showing an 8-fold increase in hospitalizations and ED visits for skin and soft tissue infections, closely followed, as you can see, by bacteremia and sepsis between 2010 and 2020. This trend definitely is still on track to keep increasing. I think between 2019 and 2022, we see a 3-fold increase in the same measure. So people are definitely contending with some very severe wounds and a lot of the sequelae that we see from that. People definitely had experienced wounds before xylazine entered the supply, but they were very, very different. So when fentanyl alone was in dope, we would see infective abscesses often at the site of injection. They might progress into small or discrete wounds. They might, or rather they always were generally healable and were able to be done with topical and oral antibiotics, as well as short-term wound care. So a provider who is seeking to offer harm reduction to a patient who used drugs would be able to offer new needles, alcohol prep pads, discussion about a switch to a non-injection route of administration that might cause less of that type of harm. But with xylazine in the supply, we're unaware. We're still not, we still don't know what the exact mechanism of injury is to tissue. We do know that it's not only injection related, which we'll discuss in a little bit. The wounds are not small or separated. They are large and maybe full thickness and very deep. We see delayed healing, not always, but often wounds can become chronic, including for years, with then a subsequent need for long-term wound care and often debridement, given the large amount of necrotic tissue we often see. And as we said, high risk for complications. And with xylazine in the supply, there's really little that providers can do to effectively help their patients avoid wounds. We can still discuss all of the considerations and do our best to support our patients being as safe and healthy as possible. But it's important to acknowledge that with xylazine in the supply, all of that is much less effective than we would like. So what we know is that with xylazine in someone's body, any tissue damage has the potential to turn into a non-healing wound. And so from this, we see that any substance use associated wounds are xylazine wounds with xylazine in the supply. We don't know the exact mechanism of tissue damage, and we don't know always, we know some, but we don't know always when on the body or where or in whom wounds will develop or when they will heal. But despite there being a huge need for additional study and research, we also can still provide effective and high quality care to patients who have tranq wounds, xylazine-associated wounds, despite not knowing some of the particular details, because care for xylazine-associated wounds, substance use-associated wounds, uses the same foundations as care for any wounds that we're familiar with. We do note some particular characteristics of many, though not all, xylazine wounds. So we see a huge, very high burden of necrotic tissue, so both eschar and slough. We see either irregular borders intermixed with islands of intact skin, which over time have a tendency to coalesce into a very large area of open wound, versus circular, discrete wounds, multifocal over the body. Often there is a very large amount of body surface area that's involved. We see full thickness wounds pretty frequently, including necrosis of underlying structures, so of bone, tendon, and nerve. Often these wounds are on extremities, but not always. As we could expect from the high amount of necrotic tissue and people who do not have housing, there is a high bioburden in most of these wounds, which we see as biofilm. There's a lot of very visible pseudomonas. Infective abscesses are still common. And again, that concern for subsequent infections and the dysfunction that can come from that. Many people experience copious and malodorous drainage. Again, not everyone, but many people. And for a lot of people, that's a major concern, since odor can be a reason that people are targeted for violence or delay seeking care. And many of these wounds, although again, not all, show very delayed healing and can become quite chronic. So what we see in terms of a progression of one version of a classic xylazine wound would be what we see on the screen. So the hand that's in the top left corner is a person who 3 days before this picture was taken had injected there. In his words, he had spilled a little bit, so he had attempted a venous injection and partially made it into the vein and partially did not. And what popped up a little bit later, a few days later, was this purple, irregularly shaped area of blistered skin. We see a lot of blistering, especially at the onset of a wound, whether or not it was related to direct injection, as well as surrounding a wound at potentially any stage. Usually what this purple will evolve into is eschar, and again, it may be intermixed with slough or with islands of intact skin, and it may cover partial or full thickness wounds. And although, again, not everyone, but many people will then experience progression to a chronic wound that may continue for anywhere from weeks to years, with periods of healing and deterioration, depending on various factors like their health, physiology, social, environmental factors. And because of this, we see a lot of people with wounds, multiple wounds on their body that may simultaneously be at different stages. One of the things that we have been able to gather some amount of anecdotal evidence around, based on our practice and the practice of our colleagues, is that we are seeing difference in wound characteristics, wound presentation, based on whether that wound is in someone who injects or doesn't, or if that area was an area of injection. So it does appear that we see maximum local tissue damage through that direct xylazine exposure, as in a missed shot, a blown vein, or when someone intentionally injects under the skin or into the muscle. Direct exposure of xylazine to tissues also impacts snorting and smoking. So again, no longer a way that we can reliably avoid harm. We see damage to mucosa as well as to nasal septa, some mild and some quite severe. Any consumption in any route of administration can result in wounds that appear to be spontaneous and show up anywhere on the body. Those wounds are more often circular and can be varying sizes, but occur away from any direct exposure to xylazine. And then, of course, any tissue damage. So if someone is unlucky enough to get a burn, an abrasion, folliculitis, insect bite, etc., that can turn into a non-healing wound, again, with the characteristics including necrotic tissue. More study, of course, does still need to be done, but from the animal studies that have been done, as well as basic pharmacology of the class of drugs, and anecdotal evidence, again, from that we've gathered in practice, we have some guesses as to some things that could be contributing to some of the wounds that we're seeing. So from xylazine, possibly peripheral vasoconstriction, blood sugar dysregulation, and thermodysregulation have both been documented in broader studies, although again, not recent and not about xylazine use as it is used in substance use disorder currently. Of course, with overdose, we are seeing a lot of hypoxia related to the respiratory depression that is from xylazine and opioids synergistically, as well as because of the sedation and muscle relaxation, people passing out in positions that cause injury, either because of lack of perfusion or pressure. Xerosis is also a documented side effect of xylazine, and so may contribute to some of the issues with skin and soft tissue. And anecdotally, we're seeing a lot of quite severe anemia that seems to track with xylazine, but again, as yet unknown. However, there are a lot of things that we know for sure do impact wounds that we as providers can support our patients with, or can attempt to support our patients with. So unmanaged chronic disease like HIV, Hep C, diabetes, infective processes related to strep A and staph, both MRSA and MSSA, food insecurities, or whether they're able to get a plate of spaghetti each night, they may still be lacking proteins and minerals that are so necessary for healing these kinds of severe wounds. Of course, being unstably housed will put you at risk for exposure to extremes of temperature and weather, not having running water for hygiene, ability to change clothes, shoes, etc. when soiled or wet, not being able to sleep soundly because of a lack of safety, and various impacts of polysubstance use. So of course, if someone injects cocaine, that will be also synergistic with the tissue damage that we see from xylazine. Here we have a couple of photos, one that we saw previously, but another example also of what direct injection can look like, again, either intentionally or unintentionally. We usually see this popping up within a few days after, but again, everyone is different and we're still not sure fully why we're seeing some of that variation. So we sometimes see this popping up a week or more after an injection or a missed shot. Here on the left, we see what was an infective abscess and then became a chronic wound. On the right, we see folliculitis intermixed with wounds that themselves previously had started out as follicular issues and progressed into open wounds. Here we see the purple discoloration in the wound bed, which indicates usually direct injection into the wound bed, again, kind of mirroring that purple that we would see under intact skin if this were in skin rather than in a wound. And this is also an example of that chemical burn type peeling and blistering around the wound.
And then in this picture, this is a great picture. It's hard to see, but if you look at the top of the patient's like forearms, you can see there's the beginning stages of xylazine wounds where this patient had recently injected, and then down on the hands, you see that there are other wounds that had been there for longer periods of time. And then in the next picture, we've got a screenshot of various patients of mine, but I want you to take a look in particular to the one at the top right, which is someone's forehead. Because the xylazine is so damaging to the blood vessels and the surrounding skin, I feel like our patients are really using various other spots to inject. This is a young woman that is out of all places to go, so she is consistently injecting into her scalp because there was a vein there. And then right next to that on the other side, you see a wound that's in the chronic phase. This person has had these wounds for over a year. As you can see, there's a lot of hypergranulation tissue there, which in this case is signaling that there's lots of bacteria there. This is a patient of mine that I was seeing that is very hard to find, very reticent to seek care anywhere other than on the street, and frequently does not have enough dressings, is unhoused, so is not able to clean themselves and to take care of the wounds appropriately. And then we have various other chronic wounds in the pictures below. So I want to talk a little bit, now that you all know about xylazine and harm reduction and the presentation of wounds, I really want to talk a little bit about building rapport and trust, because in this patient population especially, it's really the cornerstone of any treatment. You're not going to make it far with these folks unless you can gain some trust. They have been through a tremendous amount of trauma from engaging with the healthcare system in a traditional way due to the stigma that comes with using drugs. I could share some stories of things that my patients have told me people have said about them. This is healthcare workers, doctors, nurses, clinicians, etc. As well as I have interacted with people who really can, just really have a lot of bias when it comes to taking care of these folks. So in order to decrease stigma, one of the ways that you really should do that is to try to switch from stigmatizing language, which I have here: drug user, addict, junkie, whether their urine is dirty and clean, abuse, to patient-centered language, which is like a person with substance use disorder. They are not an addict, they are actively using substances, or a person in active use. Their urine is positive for certain substances or negative for other substances. It doesn't seem like a big deal, but those things push forward this stigma, and we really need to do a better job of taking that off of patients. And so instead of saying abuse, we're saying use, okay? Because when we talked already about harm reduction, for some of these people, it might not be abuse. They might be using it couple times a week on the weekends, and so they're not, and they might be working, all of these things. So you just say use, you don't need to say abuse. Next we'll talk about dressing changes and how to bring harm reduction into this space. So Rachel's already talked a little bit about this. You want to honor their expertise. Many of these folks have had these wounds for a while. They've cared for them on their own. They know what worked, what didn't. They know what they liked about a previous dressing, what they didn't. They want something that's going to minimize the pain. So I allow my patients a lot of times to start off their own wound care, taking off their own dressings. I will allow some breaks if they feel like it's just too painful. And I'm always, before I'm doing anything, especially if I'm going to use a different type of cleanser or maybe like a saline spray that's got like a really like strong PSI, I'm going to let them know and ask them if it's okay to use that. And then For the most part, I'm taking my time because rushing is really going to cause a little bit more pain. I know it's hard to not rush in this climate in healthcare because we're all busy, but it goes a long way, kind of slowing down a little bit. And that's the other reason why I let them lead the dressing changes too, because they can help while I'm doing other things. These wounds are really large. They have a lot of drainage. There's a lot of bacteria, so there definitely is odor. We're also dealing with folks who may not have changed the dressing in a few days or have old drainage on their clothes. So it's okay to offer some air freshener. It's okay for a linen spray or anything else you may have. They enjoy those things. You don't have to avoid saying that there's an odor. You just need to be mindful of how you're speaking about it and how your face is in regards to the odor, because they feel really embarrassed about it. And so if we, react to it in a certain way, a lot of times that might make them retract and not want to show it to you again or to someone else. And so Rachel already talked about this. Wounds can be a barrier to rehab and recovery. They don't necessarily have the resources to kind of support people with the care. They can make someone a target of street harassment or violence because, they got this big wound on their hand. They don't really have use of that. Someone can see them as an easy target. Many people will avoid going indoor for services for fear of odor and people judging them of the dirty dressings, etc., or just having a wound in general. And then the person may or may not want to be involved in the dressing change. I have a patient that I just saw today, and the wound is pretty much her whole forearm, and she closes her eyes the whole time because she just cannot look at it. We're working towards that, and she has made some progress, but she can't look at it. All right. So we're going to talk about like injection sites and changing the route of administration, as we've already talked a little bit about, is not going to guarantee wound prevention. That's the part that's a little bit tough. So what you want to do is just maximize the successful venous access. So showing them how to, get a vein ready, looking for a good vein. I feel like when I first started working in this with these patients, it was really something that I had to get used to, of like helping a patient find a wound to inject drugs in. It's like, whoa, wait a minute. But if that's going to prevent them from having a wound, that's what harm reduction is. And so we want to try to tell people to avoid skin and muscle popping. We've already talked about the damage that xylazine can do, even if someone has successfully accessed the vein and it just kind of leaks out. So I usually tell people to avoid skin and muscle popping because I feel like the damage is just astounding. And if they're going to snort, we're having them irrigate with saline and avoiding the rectal route completely. One other thing about that, I feel like we are at times encouraging people when they do have wounds to try to avoid injecting into the wound, but that is also sending folks to larger, more dangerous vessels like their neck and their groin. So we got to kind of balance that and know that there's other risk that comes with that. And so for some folks and for a lot of people, injecting into the wound is a way for them to kind of avoid creating a new wound. And so we need to discuss with them their goals. Our goals for healing need to be in line with them. We can discuss our concerns related to direct exposure versus a new wound for this particular person, because for some people, it depending on how things are going and where they're injecting, it may be less of a risk. Like if I have a patient that I feel like it's like going down to the bone, I might say, I hear what you're saying, but it's really dangerous to continue injecting in that spot, and letting them know of the risk of them continuing to inject in that spot. And then we want to discuss any strategies we can to minimize local tissue damage, which, like I said, maximizing venous access, and then avoid ultimatums. So it's like, if you don't stop injecting in this wound, this wound is never going to heal. And nothing matters. No point in doing that, because that's not the case. And you're trying to build rapport. Okay. So now I'm going to talk a little bit about clinical management and how to develop a wound care plan that specifically centers harm reduction. All right. So a couple things I just want you all to think about is that there are some advantages versus disadvantages. I like to look at the advantages because I feel like I come from a home care background, and a lot of my patients were elderly and had lots of chronic conditions. This is usually a younger patient population. Many of them are without chronic comorbid conditions that affect healing, right? They have a strong desire to self-manage. They are physically capable of changing dressings. They are extremely resourceful people. And there's a lot of knowledge sharing within the community. So you get in with one and show them how to care for this wound and certain things to avoid. They will share it widely, which is great. Some of the disadvantages to providing care, which we have to assess, is that they do tend to delay seeking care. So when you see these wounds, they're going to be, a lot of times they've had them for months to years. They're probably going to be more severe. And they also may find it hard to receive care in traditional settings due to prior trauma, like I previously discussed. Their housing might be unstable, or they may be living on the street. And they are frequently victims of burglary and theft. So when it comes to providing supplies, it can be hard for them to keep track of things. And so we want to discuss risk with them without shame and fear, right? So I feel like I've had a lot of patients tell me they've gone into their emergency room and they're like, you will lose your arm if you don't stop injecting. You are going to lose your arm if you leave the hospital for this visit. And so unless it's imminent at the time you're saying it, it's not a good thing to say. People have said that to my patients, and now they do not want to go back into the hospital again because they feel like if I go in, they're going to cut my arm off. Even if I say, I don't know that we're at that point. So you think it's not really a big deal. You think you're going to encourage someone to stay by kind of scaring them. It doesn't work. And then also, if you don't stop using drugs, there's nothing that can be done, or it doesn't matter. You should have come in sooner and your wound wouldn't be this bad. This is stuff that people have like said to patients, or either in a roundabout way to me. And people, these folks are not people that don't care about their health. People think that, but that's not true. They have lots of stigma, and there's lots of other things that go into the reason why they are not seeking care. And so the other thing is, like, if you cared about healing, you wouldn't keep injecting into the wound. Like, those things are just not helpful at all. It would be better to say things like, if the wound care isn't done consistently, it puts you at risk for blah, 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 blah. That's true. Letting them know what their risk over and over again is completely inappropriate. Asking them, hey, what's making it hard for you to do the care? What's making it hard for you not to use? What's making it hard for you to stay in the hospital? All of those things are important in order for you to be able to move through the process of the next steps to provide care. And so I usually say things like this: I can understand or hear you're not open to being completely free from use. So our goals for healing and care may need to be adjusted. So if you're telling me that you're not going to stop injecting into the wound, we might not be able to get to healing as quickly as you want. And I will say that. And then I might say, I understand you need to use consistently so you don't go through withdrawal, because this is what we're dealing with. Most of my patients are not using anymore because they enjoy it and like to get high. The majority of them are using so that they do not go through withdrawal. So I will say to them, is there any way you could use less? So some folks are injecting 2 bags in one shot, or they're injecting 6 bags a day. It's like, well, can you maybe inject a half a bag less in each shot? Or can you do a different route some of the time? So I know people say it's not the same if you snort it or smoke it versus shooting it. Well, maybe could you do it some of the time? Because those times really matter, taking a break from injecting into the wound. And so I most of the time encourage people and actually like congratulate them for seeing me. This wound is severe. I'm so glad you came in. I'm so proud of you that you're here and taking care of your health. It goes a long way. So clinical management history is extremely important, which with any plan of care. Onset is important because you need to know how chronic it is and like what that means. And I feel like we're all WOCNs here and doing this care. And so we know that the longer the wound has been there, there's going to be more challenges to heal it. Always ask about current or prior treatment. Like I said before, they will be open and honest with you, telling you, I didn't like this, it did that, I used that, it didn't work. You know, all of those things so that you have an idea of the things that they've tried, and you can either maybe start with something that they did enjoy as a way to build rapport and trust, or avoid something that they didn't like. And then use patterns. This is super important. So you want to know the type of drugs they're using, the amount, and the mode of use. I feel like they can get wounds from using in other ways, but for the most part, I think Rachel will agree that a lot of the severe wounds are from people that are injecting. It's not always the case, but that is the majority. And so you want to know how often they're using, because the other thing is, if someone is using 10 bags a day, that means that if they do have a wound and they're injecting in it, in order for them to get to that wound, they're going to need to remove the dressing. So all of those things are important for you to know, so that when you're picking dressings, etc., you can keep all of those things in mind. Then, of course, housing status, whether they have insurance. A lot of my patients are insured, so I am able to order supplies for them. And then the patient goals. Do they want to close it? Are they just like, listen, I'm going to keep using and injecting in it. I just don't want to have to go to the hospital. I want to try to keep my arm as long as possible. Are they only focused on odor and they don't care about healing, right? So those are things to find out in the beginning. And then from a cleansing and infection control standpoint, we're talking about a lot of folks who are unstably housed as well as living on the street. A lot of times I'm just instructing people to clean with tap water and soap. Unless there's exposed tendon or bone, soap and water is just fine. Or saline spray or hypochlorous acid. I forgot to add like diluted Dakin solution on here. All of those are really good options for these folks, because especially the diluted Dakins helps with odor. And then a lot of education in regards to cleansing, I feel like, is about avoiding cytotoxic cleansing agents. People love peroxide. They put it on there and it fizzes up and they're like, oh man, it's getting real clean. So there's a lot of education that needs to be done about that. Educating them on washing their hands. There's so many people that are just like touching, their hands are dirty, stuff all underneath their nails, and how to do dressings while keeping things clean, okay? And then the importance of keeping the wound covered all the time. Everyone is like, they told me I needed to get air. Everyone on the street feels like the air is going to dry it out and close it up. So these things I feel like are preliminary things that no matter what, you can always educate someone on. And so it's really important because it can make a difference, of course. And then from a topical therapy perspective, I'm usually trying to pick a product that's going to address multiple things. Most of the time, it's going to be something that's going to address biofilm and necrotic tissue, like a medical grade honey with alginates, an iodine or silver impregnated foam, and other like Cadexmer iodine dressings, right? I'm also thinking about how much they inject, how likely they are to change the dressing. So I'm usually looking for things that can be left in place for extended time periods, because a lot of the folks I'm seeing are not going to do a dressing change every day. And then I'm also looking for products that are going to provide a protective barrier. So something that, you know, if it's raining or something like that, if it's hot, that maybe the flies, etc., will not be able to penetrate and the person develop maggots. And then I'm looking for products that are going to cause minimal pain with applying and removal. Pain is a big thing for them. I feel like a lot of these folks have hyperalgesia because they're using, opioids. And so it may seem as if it's not really that big or painful, but the slightest touch can be really painful. So I'm always thinking about that. And then as well as thinking about how often they are using, just thinking about the nature of xylazine, I'm always thinking about minimal steps, not putting this and that and this, or using this on this wound and that on this wound, because people are not going to be able to remember that in between use a lot of times. So I want to keep it super simple and like minimal steps. And then from a harm reduction perspective, specifically, I have a very low threshold for changing the topical care based on the patient experience. If I try something and I think it's going to work well and they say, I hated that, it hurt, I didn't like it, cool. We don't need to use it anymore. There's not a whole lot of back and forth. I'm not going to try to say, oh, we'll try it, or it's supposed to do. I may say like, well, like with, medical grade honey, it does tingle a little bit. I would say, well, that's normal. It's supposed to do that. And then if they say, oh, okay, I didn't know that. It wasn't that bad. Let's try it again. I will. But if they are adamant about it, no problem at all. We will switch. And then a lot of times I might need to prioritize one goal depending on patient circumstances. So for instance, I had a woman who was doing sex work. And so I was using medical grade honey on the wound to try to debride slough. But she noticed that it was, of course, increasing the drainage and soaking through the bandages. And she said that was preventing her from getting dates and being able to work. So while I wanted to aggressively remove the slough and the dead tissue, she did not want to do that. And so I had to switch to care to something that she felt like she could manage in order for her to still be able to work, for her to be able to fund her lifestyle. And then I'm usually providing a small amount of supplies at a time if a patient is unhoused versus like a whole bunch, because again, they lose things, people steal things. You'd be surprised which things have good street value. And so people will steal their things. And so I don't give a lot of supplies at one time. And so here's a patient of mine. The pictures are a little hard to see. It was so hard to get like good pictures on here because they're so large. But if you look at the top of this picture, this was kind of like when we started seeing her. And the wounds look relatively clean, but there, if you can see, there's some slough there. There looks like there's some islands of epithelial tissue there. This was a person when we saw her, she had had dressings on, I think for maybe 2 or 3 weeks. She had had like Coban on there because they love the Coban because it like sticks to itself and it doesn't get wet. But because she hadn't taken it off, it was just getting tighter and tighter and kind of cutting into her skin. So if you look at the bottom, her hand looks like really swollen and disfigured. And that's how it was after we removed it. But this was in 3 weeks. We saw her and I think we might have seen her once or twice a week, and she did no care in between. I'm not sure what we did the first time. We might have done a silver alginate and like a foam because she would not change the dressings in between. And we saw her twice a week. And in 3 weeks, her arm looked like the bottom picture, which is really amazing. And like I said, these are people who are relatively healthy. So the healing, if we can kind of get a good regimen going, is like so fast. Unfortunately for this patient, which I feel like for most of the patients, the healing is not linear. So right now the wounds are kind of like much worse than this picture at the top. But it's just part of it. And so, we start from scratch and there's no judgment and we move forward, like nothing ever happened. And so here's a few things I do for people who are actively injecting into the wound, because that's why her wounds have kind of reverted back. She is actively injecting in the wounds, as well as she is not changing her dressings at all in between. So if we don't find her and we do not see her, the dressings are staying in place. So she may like move the dressing up or, in order to get to a spot to inject into the wound. So I'm educating her and others to clean the wound prior to injecting, just like they would their skin, clean it using clean needles and any other supplies like water, not licking the needles, the cotton, all of those things need to be clean. And encouraging them to limit the amount and the frequency in the wound if possible. And no judgment if they can't. Just a reminder, right? I've also been like just anecdotally telling people to maybe inject in one spot. So then that way we can try to get healing in other areas. And then encouraging them to use in other routes if possible, at least until the wound is closed, and finding other locations to inject, which I will assist in doing. And then I usually, because people are injecting, I try my best to do some type of topical therapy that can be removed in one piece, because I feel like if people are injecting and there's all of these pieces, I just feel like it can be a mess. It doesn't always work out, but that's what I try to do. This is all, trial and error, because it's very individual with the patients. And again, their circumstances don't always support us doing, things that we may think will work the best. And so the best way to promote consistent wound care is patient education. All of those things that we've already talked about before, making sure the care is patient-centered. So whatever they feel is working the best, trying, if they're adamant about it, the best wound care is going to be the wound care that's going to be done. So if you're seeing them and you're using something and they hate it and then they don't do anything in between, that's not really helpful. And also walk-in and open access, like a schedule. I feel like I work at Pathways office. We do not have scheduled appointments. People can walk in anytime from 10:30 to 1:30, 5 days a week. Of course, on the street, there's no appointments. We are actually riding along with 2 outreach workers in a regular, like not quite a minivan, but like a sports utility vehicle, I guess. And so we are going to people. We don't necessarily set up appointments. We have certain spaces that we go to on particular days and times, but even that is just walk in when you can be seen. Of course, street-based care. It's really great for me that some of the folks that I see in clinic, I also see in the street, and the other folks in the team see them. So if I can't see them in clinic, I can try to follow up with them in the street. I know where a lot of my folks kind of like hang out, so I can go there and provide care. We do have some locations. We have an office, like a landing space that's in Kensington, that I can take folks to that office if I need to, if there's a more extensive dressing change. And then one of the biggest things I feel like in this area that we are working on is trying to have inpatient and detox services that also provide wound care, which is like key. That time to like rest, take a break, get consistent care could be like, just being in there a month. I've seen people with the most large, heavily draining wounds just like come out and there's like nothing. So it's really important that we support those services while they are trying to take the steps to stay free from use. And then also collaborating and compiling a list of community organizations that provide wound care and supplies. I feel like Rachel and I and some of the other community organizations, we know each other, we have each other's contact information so that we are able to say, hey, you can go, if you miss me, you can go here. Rachel and I are actually going to be, we're going to be at the same shelter coming up. And so we've already been talking about collaborating for some folks that if they need care on various days, we can check in with the patients. And then ways to maximize self-management, of course, is to establish rapport like we've already talked about. These folks really have been treated so disrespectfully by others in healthcare. So we have to remember that this is not just from folks on the street. This is from people who are supposed to be providing non-biased care. These folks are being treated so disrespectfully in healthcare settings. We need to make sure that we are explaining what we're doing to someone before we're touching them. We need to be responsive in words and actions to reports and pain, slowing down, I'm sorry, okay, all of those things to let them know that we're not just rushing through it without any regard to them or their body. And then we want to reflect what's positive about wounds. So like if there's any small thing, okay, well, it's not draining as much, or it's, it is, I see that there is less dead tissue. All of those things are important to bring up when you're doing the care because it gives people hope that these can heal. I feel like a lot of people are in a space where they don't want to talk about the wounds or show you the wounds because they are feeling like this is never going to heal and my arms are going to fall off. So encouraging them is really important to getting them to buy into allowing you to do care as well as for them to do care. So acknowledging small steps, including presenting for wound care. The patient I saw today who never wants to change her dressing, I noticed that she did cover up the site where she had injected. And that's big for her. She would never do that, would just be kind of open. And I said to her, I'm really proud of you for just putting a dry dressing on there. That's amazing. And she was like, thank you. It was hard, but I've really been listening to what you're saying. And then explaining clinical assessment and decisions. Whenever I'm changing a dressing or suggesting something new, I am very detailed about why I am doing that so that they understand. And then I offer different rationales so any substitutes can be more effective. And then I'm providing the supplies for the dressing change prior to the next visit. A lot of the folks I see, even if they're unhoused, we have the ability to order supplies for them. So we're able to bring them out when we see them. And all of these can help to maximize self-management as well as healing. And then Rachel and I and some of the other community partners, if the hospital or emergency room is required, which it is, okay, not all of this care cannot be done on the street. Sometimes they need to go to the hospital. We will provide as much information about the hospital and emergency room course as possible. We might say, okay, you're going to go there, you know, they're going to need to do a CT or this or that, so that they have some idea of the things that they're going to need, how long it may take, when is a better time to go, right? So encouraging them to go to off-peak hours and days versus going on a Friday night at 10 p.m. or Saturday at 9. Also, we usually encourage people to use before going to the hospital, because if they start to go through withdrawal, they're gonna, you know, leave. And then we encourage patients to be honest about use and request addiction medicine consults upon arrival to manage withdrawal symptoms. And I have some contacts in the hospital. I know Rachel does as well. And we will reach out to them ahead of time to say, hey, this person is coming, so that we can try to get the addiction medicine consult right as they get in the door. They're aware that they're coming, because the sooner they get medication for withdrawal management, the more likely they are to stay in the hospital for whatever recommended course of treatment. And then briefly going to talk about this because I feel like we have so much and we want to get to questions, but we have, like I was talking about, some inpatient and outpatient collaborations. We've partnered with local hospital systems to create systems of making hospitals aware that patients are coming, which accelerates the supports that are coming there, and also allows bi-directional communication and collaboration so that patients can stay for care. And then we also have a community of professional collaborations. There's a wound and soft skin and soft tissue morbidity and mortality review that we're like doing recommendations from that to help people citywide to know how to take care of these folks in the wounds. Mobile teams and wound care collaboratives, citywide hospital work groups, and we're also working on some ICD-10 coding specifically for xylazine related wounds. And then one thing I feel like is really important, especially to all of my fellow wound care specialists and WOCNs, we can use help with donation of supplies to community organizations, getting involved with your community organizations to provide training or to volunteer. I feel like there's so many people that want to learn and want to do really good care, but they might not have the resources. Connect and share info amongst wound care clinicians in the community, so you're working together, offering walk-in hours or mobile services as much as you can, and advocating vehemently for withdrawal and pain management so that people can complete their hospital stay. It is really the thing that has made the most difference in our patients being able to receive care and stay, is for advocating for adequate pain management. They are using so much opioids. The opiates that they're getting in the hospital is nowhere near what they're using on the street. So some of the concerns that I feel like traditionally we're worried about, it's fine. They need it in order to get care. And so I'm going to pass it back over to Rachel, and she may go in, but I think we're going to be closing up. We've talked about so much.
We did. Yeah, this slide just highlights what Lydia was saying, which is that the milligrams of morphine equivalents are really just beyond what most of us can conceptualize, honestly, and which means that people's tolerance is incredibly high, people's withdrawal is incredibly severe. People describe it as feeling like dying. So it's quite a disincentive to staying for care or to coming back to the hospital when pain and withdrawal, both from opioids and from xylazine, is not appropriately managed. So this is more to act as a resource for anyone who is working in hospitals and is interested in knowing some details or offering some resources to their colleagues around adequate symptom withdrawal symptom management. We don't need to go into it, but of course, if anyone has further information that they'd like, we're happy to connect you with resources. This is, again, a little bit of a inspiration. We do have permission to show this, and the names of the people who created it are included in the document. So it is able to be utilized if desired, or used again as inspiration for education that one could provide, for example, to nurses on a unit for how to engage with their patients who are showing up with xylazine-associated wounds, to provide both adequate, excellent wound care, but also in a way that will not have people running to the door. This is an example of the schedule that we use. So in a model that does not have appointment times like we've been discussing, what do you do when you want your patient to follow up or to get care later on? We have a not comprehensive, but working on it, schedule of different places that offer harm reductive and or low barrier services for wound care and supplies, as well as some other things like showers or antibiotic prescribing or other medical services, so that people can themselves navigate to what they need when they need it. And here we have a recording that I may need to stop sharing my screen to have us listen to, but I believe we will be able to still, I guess I didn't, let's try this. That's a woman that I've been working with for about the last year, a little bit more, who has been on Suboxone for about 2 months now, who is experiencing closure of her wounds and is still contending with having open wounds and having to navigate various medical services that, in her experience, as we just heard, treat her as lesser than just for having a history of substance use and having wounds. And on that note, we will also just leave you with these resources, which are wonderful for people who want to learn more, either about the work that we do, about resources that may be in their community, more about street medicine, more about harm reduction, as well as the top 2 are trainings specifically for harm reduction, substance use associated wound care, and for decreasing stigma in clinical care.
Wow. My goodness. Jeez. That, man, that was dense. And I tell you what, every piece of information you had there was necessary. So I want to thank you both. Just terrific presentation. There are a couple of questions that I do have. And I think it goes back to the desire to limit, and in this case, injecting in the same place. So what that's telling me, and please, correct me, what that's telling me is that these large wounds that we see are not a result of the dope and xylazine penetrating peripherally. It's more a result of the user finding a different spot to inject. Is that correct?
So let me make sure I understand what you're saying. So
Yeah.
you're asking if the wound, them injecting into the wound, is the xylazine itself is continuing to cause the wounds, or
I'm talking about the size of the wounds that we're seeing.
oh,
Yeah.
Okay, so is the size influenced by the movement of the injection site, or just made larger because the chemical?
no, yes, that's
Refuses.
exactly what it is. It doesn't have anything to do with like them jumping around. Like they could inject one time in one area, and then it starts out like I feel like when this first started, everyone was coming in with these little small like black dots, and we're like, what is this? And then they just, as the days progress, they get larger and they turn into these gaping holes. Or it's like a small circle, and then they'll say, all of a sudden it got more swollen and it's just like opened up like out of nowhere. I feel like people are like, I woke up and then it was so much bigger. So it has nothing to do with moving around. It could just spread just from injection. And that's whether they're doing it in the wound or whether they're doing it in other spots.
Now, I've heard that with xylazine use, you can actually, and this may not be true, but you can actually have a wound develop away from the injection site.
Absolutely.
Okay.
Yes. So what we're seeing between kind of your previous question and this bit is both and. So yes, we are seeing people develop wounds that are bigger than any single injection, that are away from any injection or injection site rather, and in people who don't inject at all, who may exclusively snort or smoke. And we are also seeing especially severe tissue damage at a very hyperlocal site of injection or wherever that person did end up, because some people do move somewhat. So I think to some extent it's both and, but yes, people definitely get wounds where they don't inject and get wounds that are much bigger than any single missed injection could ever be.
Wow. Changing gears here in terms of street medicine. Prior to this presentation and prior to meeting Rachel, this was a practice that I had never heard of, hadn't been aware of, and wonder why it's been so quiet for so long. You know, it's incredible. Now, obviously, there's a stigma to treating drug users, and I could understand how that would be maybe an influencing factor in terms of it not getting a lot of popular press, if you will. For Philadelphia to have organizations like this, do you need to be a big city, or are you aware of smaller areas that have similar types of services?
Mm-hmm.
Mm-hmm. Yeah, including some rural areas, I believe, where, yeah, my understanding, I unfortunately don't think I can point to any particulars, for which I apologize, but I have heard of people talking about how in rural areas where any brick and mortar medical services may be very few and far between, that mobile and or street-based services are of utmost importance and are heavily utilized sometimes anyway.
Fantastic. Oh boy, you guys take it to a whole new level. It's just awesome. Thank you so much for sharing your expertise, and I would invite you back in the future if you have new insight that you'd like to share as well. This has been totally eye-opening, and I have always practiced in the city, so that I'm looking at this and saying, my goodness, there's just so much that I was not aware of. And I totally appreciate that with the drug users, we're dealing with a population that has a different perspective.
Mm-hmm.
And it's something that requires our adjustment to their needs.
Mm-hmm.
So
Yes.
thank you. Thank you. Okay. This ends this presentation. Please be sure, as the attendee, please be sure to complete and submit your evaluation to earn your CEs for watching this presentation. The deadline for submission is December 31st, 2023. My God, I needed a time machine. 2023. Rachel, Lydia, thank you so much for your time. Thank you so much for your efforts, and my goodness, thank you for your practice.
Thank you. Thanks for
Thank
having
you
us. It
so
was our
much, Brian.
pleasure.
Appreciate
Very
it.
much so.